Hello, this is the Implantation training module for the VWING Vascular Needle Guide. This module will help you prepare for performing the VWING surgical implantation procedure. Vascular access is the lifeline of the hemodialysis patient. Vascular access requires a team effort with surgeons, nephrologists, and dialysis clinic staff all working together to ensure safe and reliable access for the patient. The VWING Vascular Needle Guide is a tool that can help facilitate access to a patient's arteriovenous fistula, or AVF. However, the VWING is a new device that may not be well known to healthcare workers providing care to hemodialysis patients. The vascular access team must be informed of the VWING and ready to support its use in helping to facilitate safe and reliable vascular access. The VWING Vascular Needle Guide is indicated for use as an access device accessory on arteriovenous fistulas, or AVF, for hemodialysis procedures using a constant site method of needle insertion. It will facilitate access to fistulas. The goal of the implant procedure is to give cannulators a palpable target that is attached to the fistula and is well aligned, both axially with the fistula and parallel to the skin. The VWING Vascular Needle Guide aids in fistula access and directs the dialysis needle to a single puncture site on the vessel wall. The VWING is a single component device made from pure titanium. It does not have a septum, reservoir, or catheter. The device includes suture holes for attachment to the fistula, a palpation ridge for detection under the skin, and a funnel to guide the needle to the cannulation window and the vessel wall. The VWING is implanted under the skin and attached to the outside of the fistula with sutures during an outpatient surgical procedure similar to an AVF creation procedure. The device is intended for use for the life of the fistula. The VWING is available in heights of 4, 6, 8, and 10 millimeters to accommodate patients' unique anatomies. The key criteria for VWING patient selection involve vessel diameter and depth. The patient's fistula must be 5 millimeters or greater in diameter. Vessels smaller than this may result in the VWING distorting the vessel or in an increased risk of back wall puncture. The fistula should be between 4 and 15 millimeters deep. Vessels greater than 15 millimeters deep cannot be reached using commercially available needles. AVF hemodialysis patients who could possibly benefit from a VWING device include patients who are catheter dependent with difficult to access fistulas, patients who have a deep, short segment, aneurysmal, tortuous, or unpalpable AVF, patients with an AVF that requires elevation or transposition, patients who want to self-cannulate, and patients undergoing home hemodialysis. The VWING may be placed on fistulas that are new or existing. Although extremely rare, it is important that the patient is not allergic to titanium. Mapping of the fistula and VWING locations prior to surgery is important in facilitating successful cannulation at the dialysis clinic. Ultrasound is used to map the fistula and mark the margins of the vessel on the patient's arm. The optimal VWING location or locations are then chosen. The decision to use one or two devices is based on the cannulatability of the patient's AVF. If there is a readily cannulatable section of the fistula, the patient may only need one device. Determine and mark the optimal device locations on the fistula where the fistula is between 4 and 15 millimeters in depth, where the fistula has a diameter of at least 5 millimeters, where there are no large feeders, where there is a straight segment of at least 3 centimeters, where there is spacing between cannulation sites of at least 5 centimeters, and where the location will allow for ease of cannulation, avoiding proximity to the antecubital fossa and the axilla. An attempt to identify locations with maximum diameters and minimum depths should be made. Commercially available needles will not be able to access a fistula that is greater than 15 millimeters deep, and placement of the device on small vessels increases the risk of back wall puncture. Remember to record the depth and diameter of the AVF at each VWING location on both the VWING implant notification card and the VWING notification form. Once the preferred VWING locations are identified, the skin incision is marked. The incision should be approximately 2 centimeters to either side of the fistula and approximately 4 centimeters in length. The incision should be parallel with the vessel and should not interfere with the VWING palpation or cannulation. One incision is made for each VWING. Ultrasound is the best way to determine what size implant is used. It is important to use a light hand with the ultrasound to get an accurate measurement of the vessel depth and diameter. It is best to match the vessel depth with the implant height. The VWING is provided in 4 different heights: 4, 6, 8, and 10 millimeters, to accommodate fistulas of a range of depths. The pre-surgical ultrasound will provide an indication of the VWING size to use. The final determination should be made following vessel exposure. The VWING height should be selected to provide the best palpability. In general, the height of the device should match the depth of the fistula as closely as possible. For example, if the fistula is 6 or 7 millimeters deep, a VWING with a height of 6 millimeters should be considered for implantation. VWINGs with a 7 millimeter width will accommodate most fistulas. However, for fistulas with a much larger diameter, use of a 9 millimeter width VWING may be considered. The surgical procedure is initiated with thorough injection of local anesthetic at the surgical site. Once local anesthesia is achieved, the skin incision is made at the predetermined location. To help minimize seroma formation and increase stability of the VWING, it is suggested to make a skin flap directly under the dermis and over the vessel. The skin flap is retracted, and the subcutaneous tissue directly over the fistula is dissected down to the vessel wall. The surrounding tissue should remain in place to help provide VWING stabilization and prevent the formation of a void or cavity. If needed, a curved extension of the incision may be added to provide adequate vessel exposure, so long as the extension does not interfere with the implant site or with the cannulation site. Approximately 3 centimeters of the most superior aspect of the fistula is exposed to the adventitia layer, ensuring that the VWING location will not be under the incision. To maintain fistula and VWING stability, do not mobilize the fistula. Fistula feeders may be tied off as needed. Although not common, the fistula may spasm due to the surgical exposure. When this occurs, the vessel diameter can be severely restricted and fall below the 5 millimeter requirement. It is critical that the vessel diameter be restored to 5 millimeters or greater prior to proceeding with the VWING implant procedure. Warm saline, proximal occlusion, or physical manipulation or flicking may help to bring the vessel back to an acceptable diameter. If the vessel remains below 5 millimeters in diameter, the VWING should not be placed. Select the appropriate device size based upon the ultrasound measurement of the fistula and confirm the sizing with visual observation of the exposed vessel. The VWING is packaged in a double chevron pouch and sterilized using gamma irradiation. Once the appropriate VWING size has been confirmed, the device packaging should be opened by a member of the hospital staff. Once the fistula is adequately exposed and the appropriate VWING has been selected, the VWING can be placed on the fistula to determine proper location and orientation. The location should be away from the incision and should leave at least 1 centimeter of straight vessel beyond the device to avoid vessel wall puncture at a bend in the fistula. The VWING orientation can be either with an antegrade or retrograde cannulation direction for an arterial site, but must be in an antegrade orientation for a venous site. Note that the device funnel faces in the opposite direction to the cannulation direction. The VWING should also be oriented so that the palpation ridge of the device is parallel with the skin surface. If the device is tilted relative to the skin surface, cannulation may be difficult or even impossible. The center line of the fistula may be marked to ensure proper VWING orientation while it is sutured to the fistula. Suturing is initiated through the orientation suture holes in the center of the front and back of the device. The orientation sutures facilitate centering of the device over the fistula. A non-resorbable suture, such as a 4O to 6O Prolene on a BV1 needle, must be used. The needle must take full wall thickness bites through the wall of the fistula to ensure proper VWING stability on the fistula. VWING location and orientation should be checked following placement of the orientation sutures. The remaining 8 suture holes are then used to secure the VWING to the fistula. An interrupted stitch technique should be used with the needle taking full thickness bites through the wall of the fistula all the way into the vessel lumen. As the VWING is sutured in place, appropriate VWING location and orientation should be checked. Following suturing the VWING to the fistula wall, palpability of the VWING is determined and adjusted as needed. The skin flap is pulled over the V-wing, and the V-wing is palpated. The U-shape of the palpation ridge of the V-wing should be distinctly felt with light pressure of the finger. If the palpation ridge cannot be distinctly felt, the palpability should be adjusted by lipectomy or compression of the tissue, creating a pocket over the device. Thinning the tissue flap to the dermis over the V-wing has been found to provide good palpability. Additional lipectomy may be needed on all sides of the V-wing so that the fat is flush with the top of the V-wing. This may result in an indentation above the V-wing, which provides for easier palpability and a better needle angle for the cannulators. This is most common on vessels greater than 10 millimeters deep. However, keep in mind that supporting tissue on the sides of the device should not be removed. The palpability of the device should be similar to the cannulation simulators. Another way to determine if the skin will allow adequate V-wing palpability is to have the surgeon see if they can feel their fingernail through the skin flap. Once the V-wing palpability has been optimized, the surgical site should be closed and dressed using accepted procedures. V-wing orientation should be checked as the skin flap is pulled over the device to ensure that the device has not been tilted by the subcutaneous tissue. Subcuticular suturing is preferred in order to minimize the scar. An addition of a subcutaneous stitch may be helpful to secure the surrounding tissue and the device, as well as to put the skin flap in the correct position. The V-wing implant notification card found in the V-wing packaging must be completed and mailed back to Vital Access. This information is required to provide clinical support and training at the dialysis centers. It is self-addressed and the postage is paid. Additionally, a patient ID card, also found in the V-wing packaging, should be completed and given to the patient. To provide more detail about the surgery, the V-wing notification form may be completed for the patient's chart. The form may also be sent to the patient's dialysis unit to notify them that the patient has V-wings to be used for cannulation. The notification form can be found on the Vital Access website, www.vital-access.com, or copies may be requested from your local device representative. Before cannulating, the V-wing surgical site should be allowed to heal for at least 3 weeks. This period allows for the incision to heal, for any residual swelling to subside, and for the V-wing to stabilize on the fistula. The 3-week healing period is believed to be an important part of reducing the risk of infection. Tissue adhesion to the device will help prevent bacteria from colonizing around the device. Determination of cannulation readiness at the V-wing sites should be made by conducting an ultrasound assessment of the fistula, assessing the healing of the surgical site, and assessing the palpability of the V-wing. The palpation ridge of the V-wing should be distinctly palpable with light finger pressure. If a determination is made that the site is ready to be cannulated, the dialysis clinic should be notified. This can be documented by completing the cannulation clearance section of the V-wing notification form, which can then be sent to the patient's clinic to make them aware of the patient's cannulation readiness. In summary, implanting a VWING vascular needle guide to facilitate fistula access is a simple procedure. The vessel is mapped and marked using ultrasound. This allows for the best implant location to be chosen, for the device height to be determined, and for the skin incision to be marked. The incision is made and the vessel is exposed by dissecting under the dermis and then down to the fistula. The implant size is finalized by placing the device on the fistula and by confirming the fit. The V-wing is aligned with the vessel and skin surface. The device is sutured to the vessel, ensuring that the sutures pass through the full thickness of the vessel. The palpability is adjusted as needed to ensure the device will be easily detectable by the dialysis center. Finally, the incision is closed and allowed to heal for approximately 3 weeks. If you have any questions, please feel free to contact Vital Access for a discussion with our clinical staff.